First of all, thanks to Richard and the Foundation for this invitation to address you. It's a pleasure. I'm going to talk about the irritable bowel syndrome. And for those of you that don't know, irritable bowel syndrome is really a huge problem. It's a huge problem for patients. It's a huge problem for physicians, and it's a problem for our society and our healthcare system. It's a chronic abdominal symptom complex in which abdominal discomfort or bloating, pain is one of the features associated with altered bowel habit, but for which on extensive investigation you can't find really any structural abnormality to explain the symptoms. It's a disorder of function. Bloating is a particularly troublesome symptom in irritable bowel syndrome, and a substantial proportion of IBS patients exhibit some degree of psychiatric comorbidity, depression, anxiety, somatization. And I think this has in some ways prejudiced conceptualization of this condition over the years. This is a challenging problem because it's highly prevalent. It affects 10 to 15% of the population. Not all seek healthcare from this. When we investigate these patients, because they have altered bowel habits suggestive of perhaps organic disease, the bowel looks pristine. It looks normal. And there are no chemical or other diagnostic markers. And so this is really a diagnosis of elimination, despite stringent efforts to try to classify this condition and develop diagnostic criteria. These are really of very little use clinically. They're usually for including patients into clinical trials, these Rome criteria. Because we really have no idea what this condition is or what this set of conditions is, it's very hard to develop in a rational way drugs to treat it. So all the drugs are symptom-based. Many of them have been developed for other uses and find their way into IBS. And they're of very limited efficacy, these drugs. Side effects are common because the gut's a highly integrated system. If you mess with one part, you'll affect something else, almost invariably. And the FDA, for example, has zero tolerance of any side effects for any new drugs in this condition. And so the pharmaceutical industry, after taking a number of big hits, has basically withdrawn from it completely. And whatever drugs there are, there's often very little in the way of reimbursement from government or from insurance companies. It costs a huge amount of money. The amount of money it costs in direct and indirect costs to our healthcare system is disproportionate even to its high prevalence. And so it's a real problem for all of us because we're paying for it. And everybody, as I said, is frustrated and dissatisfied. Patients, healthcare providers, and healthcare administrators. So a frequent comment by patients is that when they've gone to see a physician, sometimes a family physician, sometimes even a gastroenterologist, they come away with the idea their symptoms weren't really listened to, and the implication or the statement was, this is all in your head. And this stems from the traditional view of this condition as being psychosomatic, which can mean a lot, anything to anybody. But it's a condition where psychiatric symptoms dominate, where the absence of objective findings on testing tends to reinforce the notion that this is a condition that is largely imagined, or if you believe in the gut-brain axis, which I do, that the psychiatric comorbidity and the sensitivity to psychological stress somehow drives dysfunction in the gut, and this produces symptoms. So this is a model that's been out there for close to a century. And based on this model, as you can see from the previous slides, really very little progress has been made in helping these patients and alleviating the huge costs to our healthcare system. So what I'm going to try to do today in the context of the microbiome is try to make the case to you that there is reasonable evidence to support the notion that the microbiome may play a role in the expression of at least a subset of IBS patients. I'm not going to claim it accounts for all of the patients. In the slides, one of the slides that I think John Marshall showed indicated that there is a group of patients based on a certain analytical approach that don't seem to have any abnormality, at least in composition of the microbiome. Whether function was altered is another story. So this is really based on a model that says that there are peripheral triggers, such as infection, antibiotics, dietary change, that destabilize the microbiome, and that this produces GI symptoms. And I'll make the case later on that this may actually influence the psychiatric comorbidity that we see in these patients. So what is IBS is a common question that patients will ask. How did I get it? What factors brought it on? And we will deal with that. So in the context, so what do we know in terms of the triggers that will either bring on, that cause the condition in the first place, punctuate its onset, or punctuate exacerbations? And these are infections, as you've heard from Dr. Marshall, antibiotic usage, stress. Probably the most common story that you hear in patients is that there's a lot of stress on when they have exacerbations or at the onset of the disease, and dietary changes or dietary indiscretion as a factor that can precipitate symptoms. So I'm going to try then to build that into this model for you and show you the evidence. And the evidence I'm going to show you is partly based on observations in humans, but some of the questions and some of the studies that we do, you simply can't do in humans, at least not yet. And so we have to do it in either mice or rats. So antibiotic administration, and what does that do to the gut? So this is a study in mice, of course, and these two pie charts here show you the distribution of bacteria before and after the administration of an oral antibiotic cocktail. And the point I want to make to you is that the antibiotic cocktail, broad as it is, did not by any means wipe out the bacteria. It just simply shifted the relative proportions of the bacteria that are present. It changed it's altered the composition. It hasn't reduced the total number of bacteria. And there are a number of studies then that have shown that using this approach that resulted in an increase in pain and an increase in a change in motility. I won't go into all the data, time doesn't permit. So by using this strategy where you give antibiotics to make a subtle shift in the microbial composition of the gut, you can reduce pain thresholds in a mouse, and you can change the transit time in a mouse, okay? So shifts in the microbiome will cause changes in the areas of gut physiology that are considered relevant to IBS, pain and motility. Stress is a big thing in IBS, and there are some human studies where they've stressed individuals in a controlled environment and measured the microbiome before and after. All of these studies, virtually all of these studies were done on astronauts, and most of them in Russia. And as you can imagine, there are many other factors that could account for why a spaceman after a stressful confinement should have an altered microbiome, given things like diet, pressures, and everything else that they experience. But there's an extensive literature now in animals to show that if you stress either in the short term or in the long term, mice, for example, or rats, you change the microbiome and you can induce an inflammatory response as a result. And I won't go into all those details. In addition, you can induce depression and you can induce anxiety in mice, and that will result in a change in the microbiome. And we can discuss it later if you want in terms of mechanisms. So stress can change the microbiome, and changes in the microbiome, as I showed you earlier, can change gut function in the areas that are relevant to IBS. Dietary indiscretions are common in young IBS patients, going through the drive-through and coming out the next day and going to their doctors because they feel awful. We do too sometimes. So all the food that we really do love but never care to admit has been shown, the components of this kind of diet have been shown to alter the microbiome. So a diet that's high in fat and low in fiber in humans produces changes in the microbiome. The changes are not predictable. So if you take 7 individuals and put them on this regimen, you'll get a change, but the change will be different in different individuals. Okay, so high fat, low fiber. Caloric intake is also related to the microbiome composition. So a high caloric intake is associated with a reduction in diversity, and the converse is true. Caloric restriction improves diversity. How that happens, we don't know. We can speculate, but... And also, meat has been shown, beef particularly, to influence the diet, the microbial composition of the gut. It's very dramatic in animals. It's less dramatic, but nevertheless significant in man. And there's a recent study that showed that the way that meat is cooked, whether it's boiled or fried, have different effects. Presumably the presence of the fat in the cooking oil has some influence there. So the way that meat is prepared may also have an effect. If you ask me which of the two is beneficial in terms of giving you the right kind of microbiome, we can't say. It's simply an observation that the method of cooking seems to influence the microbiome. So John touched on this about the composition of the microbiome in IBS patients. As I said earlier, it doesn't apply to all IBS patients. We heard at the beginning from Richard that there are many different ways to analyze or to measure the microbiome, particularly using DNA sequencing. And there are various depths of sequencing that you can go to. And so it's very hard to make comparisons between studies that use different protocols because they go to different depths of sequencing. So strictly speaking, they're not that comparable. So these are all limitations of the field. And if you ever read any of this microbiome literature as it relates to humans, one of the things that really jumps out of you is that it's one of the few fields where you can publish a paper in a top-tier journal like Nature, Science, or PNAS with an N of 1 subject. I think the record is a paper in PNAS where they studied one infant for 2.5 years. And got it published in a journal like that. Very, very small N values. And the reason is that the burden of work, as somebody said, comes really in the analysis rather than the acquisition of the data. So to date, the bottom line is that no microbial signature has yet been found that will say, if you've got this profile in your stool or in your biopsy, you've got IBS. That hasn't happened and probably won't happen for a while yet. But the most consistent findings are an increase in firmicutes, a reduction in Bacteroides, and almost universally a reduction in the two commonly probiotic type bacteria that exist in the gut, the bifidobacteria and lactobacilli, a fairly consistent finding. There's invariably in these studies, there's a reduction in diversity, in richness, and there is temporal instability. This is one of the few areas where they've done longer-term studies, followed the same individuals out, and shown marked fluctuations in the composition of the microbiota. Unfortunately, what they didn't do in those studies was correlate it with the fluctuations in disease type or severity, which is something we're currently doing now. And if you take all the IBS subgroups, the patients who exhibit the biggest fluctuations in the microbial composition of the gut are those with diarrhea-predominant irritable bowel syndrome. So one question might be, is this cause or is it effect? Because if you go back to the slide where I showed you that just perturbing the microbial composition of the gut a little bit with an antibiotic changes gut physiology. And we know that gut physiology determines the physico and chemical habitat of the bacteria, the condominium of Richard's condominium. So the physiology of the gut determines the condominium. Okay, so if the people inside the condominium can also change the condominium, you can see a vicious cycle that might then lead to chronicity. Because we know that in healthy individuals, perturbation of the microbiota with any of these insults results in a transient change in the microbial composition. But in patients with IBS, it tends to perpetuate. So is it cause or is it effect? And there's one study here that took stool from patients with abdominal pain and IBS and took the stool and colonized germ-free rats. And when the rats were colonized with this stool from IBS patients, they found that when they measured pain thresholds, abdominal, visceral pain thresholds in these, and you can do that in these rats, that the pain threshold, the pain responses were changed. They were higher. Okay, so there's something in the stool that alters gut physiology, which argues in favor of a causal role of the microbiome in the altered physiology and then perhaps in symptom expression in IBS. We've extended these studies to show that you can alter transit, and when we've taken patients who have very high levels of anxiety, we're able to induce anxiety in the recipient germ-free mice. When we colonize them with the stool of very anxious IBS patients. So these are in favor of the microbiome being causal rather than an epiphenomenon. So what about the brain and what about the psychiatric comorbidity in these patients? It's very common. So the question then emerges, does the intestinal microbiome influence brain and behavior? And I won't go into all of the studies that we, excuse me, and others have done to prove that there is a linkage. So the first line of evidence are studies where you take germ-free mice that have never seen a microbe, and then you assess the behavior compared to mice that are normally colonized, and it's very different. Without bacteria, the mice, they take, for want of a better word, risky behavior. They become gregarious and they subject themselves to risky situations. And you can argue that the microbiome, when it comes in, is there to control the host because it's in everybody's best interest that you live. As I've shown you, using the strategy of disrupting the microbiota with antibiotics will change brain chemistry and it will change behavior. And we and others have shown that. And you can do the same with diet. Somebody showed that a beef-enriched diet in rats results in improved memory and improved learning and corresponding changes in brain chemistry. Also, probiotic bacteria can influence brain chemistry and normalize, in some instances in these mouse models, abnormal behavior, particularly anxiety-like behavior. And then finally, we've shown that you can adoptively transfer components of the behavioral phenotype through the stool, through the microbiota. And laboratory mice are like humans. There are strains that are very calm and very easy to handle. And then there are strains that you use them because of their genetic makeup, but they're nasty creatures. They jump all over the place, students and everybody hates them. And so we have these. And so if you study the microbiome in these different strains, they have different microbiota profiles. They have different behavioral profiles and different microbiota profiles. And if you raise these germ-free and then colonize, for example, this calm mouse, which is a bulb C mouse in this case. Where's the pointer? This guy. If you take this mouse is a microbiota and put it into a Swiss mouse that is a nasty mouse, a germ-free Swiss mouse, and let it grow up, it becomes less nasty, it becomes more calm. And you can do the converse. You can take the nasty mouse, take its stool, its microbiota, and put it into a germ-free calm bulb C mouse, and that bulb C mouse, using standard psychometric testing, will behave in a much more aggressive way. Okay? This has implications for transplantation, of course. This isn't restricted to mice. A recent study from Emmer and Meyer's group showed that the administration of a group of probiotics administered in fermented milk could change behavior and brain activity in healthy women given an emotive challenge test. This challenge test provokes emotion, it provokes predictable changes in brain activity, and this change in brain activity was attenuated in the women who had received the probiotics plus the fermented milk. So I hope I've given you some evidence then that the things that trigger IBS in terms of onset or exacerbation can also trigger changes in the microbiota, changes in gut function, and changes in brain chemistry and behavior to explain, at least in a subset of IBS patients, how this condition might be expressed. I'll move quickly on. How can we manipulate this therapeutically? Well, we've heard a lot about probiotics. There are prebiotics. There's transplantation, as you've heard, and there are other modulators. You've heard of all the issues surrounding probiotics, the quality of the trials, the fact that no two probiotics are very similar. But there is, using a meta-analysis, a suggestion that they are beneficial. And in Canada, Health Canada has approved 2 probiotics for use in irritable bowel syndrome, Lactobacillus plantarum, and the bifidobacteria that you've heard so much about, Longum subspecies infantis, or bifantis. One's called Align, you've seen it on TV, and the other one's called Tuzan, a little bit harder to get. Prebiotics are a better way to go, because a prebiotic is the substrate that selectively promotes the growth and maintenance of a particular beneficial bacteria. And the one that everybody is trying to promote is Bifidobacterium. In addition to the beneficial effects on the host that Karen showed at the beginning, these are non-gas forming bacteria, so it's particularly helpful in patients with IBS who have bloating. And there is one product out there that I know of, which is this transgalactic oligosaccharide developed by Glenn Gibson at Reading University and available on the internet, that has been shown in IBS to produce some improvement. I think this is an understudied, underappreciated area. And then we come to fecal transplantation, and as already been mentioned, there's really only anecdotal evidence. I think the time will come when this will be subjected to formalized trials. And the problem is with IBS patients, where there is so much frustration in terms of available therapies, that this could get out of control with patients getting it from non-medical, non-supervised sources. And as has been said, we don't know what we're transmitting, either in terms of potential pathogens or phenotype, Because if I were going to have a fecal transplant, I'd want to know a few things about the patient. I'd want to know how fat and thin they were, or thin they were. I'd want to know if they've been to prison. I'd want to know if they're insulin resistant and all the rest of it. And it gets worse. So not an easy area, and I think we have to be cautious in terms of jumping into it. Other microbiome-directed approaches include rifaximin. Rifaximin is an antibiotic that is approved in Canada for use in hepatic encephalopathy, and there's a great deal of interest south of the border in its use in irritable bowel syndrome. It's been shown in irritable bowel syndrome to improve symptoms. The interpretation of those results is controversial, and it remains to be seen whether that becomes available or indicated here in Canada. FODMAPs becoming very popular. There's a lot of interest in these diets. These are fermentable oligodimonosaccharides and polyols. And initially, the beneficial effect of reducing these from the diet was because you reduced an osmotic load. But clearly, these are substrates for fermentation. And giving a low FODMAP diet to patients with IBS does reduce breath hydrogen analysis as a surrogate marker of bacterial fermentation. So this is probably more relevant to its mechanism of action in IBS. So in conclusion then, I hope I've convinced you that there is reasonable evidence both from the laboratory and from clinical studies, that the microbiome could play a role in a subset of IBS patients to not only generate intestinal dysfunction and intestinal symptoms, but perhaps to contribute to the accompanying psychiatric comorbidity. So thanks for your attention.